easier topics that are in here in neuro. In step 1, we discussed vertigo under the topic of the ear, basically. They don't really separate the ear and the eyes here that much. I mean, the very last topic here is ophthalmology, so it has its own little thing, and I guess this section would be considered the ear section. So we'll revisit the step 1 aspect of this too. Vertigo, before discussing conditions that cause vertigo, we're defining vertigo and differentiating it from lightheadedness. Dizziness is often used to describe vertigo and lightheadedness. This is very similar to how people come in describing GERD as chest pain, right? It's not really chest pain, it's heartburn. But the common folk use terms as they see fit. Vertigo feels as if one or one's surroundings are moving when there is no actual movement. Lightheadedness feels as if one is about to faint or pass out. Conscious sensation of vertigo occurs in the cerebral cortex as a result of an error signal of observed over expected from the lower centers, right? So basically your brain is getting the wrong signals from your the 3 canals in your ear. That's one of the main places where vertigo basically originates from, and it's all related to the vestibulocochlear nerve, mainly the vestibular part, and different kinds of sensations, either because of a stone in the ear or fluid imbalances in the ear after an infection, stuff like that, can cause people to feel like things are moving even though it's not. So your brain is seeing something, but your brain is receiving different messages. So the messages that the brain is receiving don't match what your eyes are seeing, and that's what leads to this confusion that you have in patients with vertigo. The first one is BPPV, the most common thing that gets tested, right? Benign paroxysmal positional vertigo. Common cause of recurrent peripheral vertigo resulting from displacement of an otolith, a stone in the ear, that leads to disturbances in the semicircular canals. Patients present with transient episodic vertigo lasting less than 1 minute, and nystagmus triggered by changes in head position, so while turning in bed or getting in and out of bed or even reaching overhead. Patients may complain of vertiginous or non-vertiginous dizziness or even lightheadedness, which is really going to be pretty confusing, but again, this is just their terminology. This is why when I'm reading questions on any UWorld, IMBOSS, any QBank, and the first sentence says, oh, the patient came in complaining of chest pain, I don't underline the chest pain part, right? Because that's just the patient talking. I underline the things that came out of the physical exam and the labs. The things that the doctor is saying, I underline that, but not the patient saying they have chest pain. I don't even underline it when it says the patient said they have palpitations or anything. Whatever the patient said is not what I underline, because that's not what I'm really going to take into account, from that first sentence when I'm trying to pick an answer choice, right? So don't pay too much attention to that. Now, diagnosis is made by something called a Dix-Hallpike maneuver. You have the patient turn his or her head 45 degrees right or left and go from a sitting to a supine position. If vertigo and the typical nystagmus are reproduced, then it's BPPV. So you basically just have them turn their head 45-degree angle and then just lay down. And as they're coming back down onto the bed, they might have dancing of the eyes or just feel like the room is moving when the room is not really moving, and they're not really moving that much either. It's like they're just laying down, and that's kind of going to reproduce the movement of the stone in the ear because of the way they're turning their head and kind of falling backwards. That movement of the stone is what's going to cause them to feel that vertigo. Nystagmus that persists for more than 1 minute, or gait disturbance or vomiting, should raise concern for a central lesion, right? Something in the brain, either a hemorrhagic lesion, ischemic lesion, or maybe even a tumor. Now, you can read more about the Dix-Hallpike maneuver just by looking it up on Google, but generally speaking, all you do need to know is that some movement of the head and then full movement of the upper body. So a tilting of the head and the full movement of the upper body is causing them to feel vertigo. And that can happen in many ways. I mean, one of the other ways this may often be reproduced in a question is that the patient might be working somewhere where they have to pick up boxes from the floor, and every time they bend down to pick up the box, they often fall. Right? So a lot of these vertigo patients are actually going to have initial presentation in the question with oh, this person fell, and then because they fell, now you have to figure out why did they fall. And more than often, these questions about a patient that fell is going to involve a very young patient, somewhere between 20 to 40, not anything over 40. And then you're really like, okay, but this person has no reason to fall. Like, you're not, over 60 where maybe falling is a little more acceptable. So then that's when you start thinking other reasons that could have made the person fall. There's something called the Eppley maneuver, another thing that you can go ahead and look up on Google. It's an extended version of the Dix-Hallpike maneuver used as treatment, and it resolves 80% of cases. So I did look this up in Google, and I read more about it on Wikipedia. And basically what it was, you get the person laying down, right, with their face facing up, and you just tilt their head in different directions in a way to kind of make the stone in their ear move from one place to another, and you're trying to get it to a certain place. Now, I can only imagine that the person that carries out the Eppley maneuver must have extensive knowledge of the movement of an otolith and the design of the 3 semicircular canals in the ear, because I can't imagine how they know where the stone is really moving, but they keep doing it until the patient feels like they feel better. This is something you can do with yourself. You can keep moving your own head, and depending on how much vertigo you feel or how much nystagmus is occurring, you're getting somewhere with it. The condition usually subsides spontaneously in weeks to months, but 30% recur within a year. Long-term use of anti-vertigo medications like meclizine are generally contraindicated, as they have limited efficacy, they are sedating, and they inhibit vestibular compensation, which may lead to chronic unsteadiness. Right? So not the best thing to do. Right? So this BPPV, this is one of your peripheral vertigos. Right? So you can see questions on CK are going to try to get you to first identify whether or not this is a peripheral vertigo or a central vertigo. Central meaning really something that's occurring in the brain itself, right? So there's going to be key differences between the two, and we read some of them right here, right? That patients who have the nystagmus lasting more than a minute, any ataxia, or vomiting, those are more concerning for central lesions, right? Here they also tell you central vertigo would have may have any trajectory not inhibited by fixation of gaze, not fatigable, so it can last more than a minute, and no latency period, right? So it can just happen for a very long time, and it won't stop. You can also know other possible neurologic signs like hearing loss, several postural instability, and other CNS symptoms of, as we saw here, vomiting, but also headache, diplopia, dysarthria, not being able to talk correctly, and some of these other things that are all going to be basically red flag symptoms that are going to make you think this isn't just peripheral vertigo, what we normally call vertigo. This is central vertigo, which is going to be related to stroke, multiple sclerosis, or just chronic migraines that are possibly related to really bad uncontrolled hypertension. Right. Next one here they mention is labyrinthitis. So this is acute peripheral vestibulopathy. This presents with acute onset of severe vertigo, head motion intolerance, and gait unsteadiness accompanied by nausea, vomiting, and nystagmus. Right, so this is really going to feel like central vertigo. Labyrinthitis is an auditory or oral symptom. Lateral pontine cerebellar stroke may present with similar symptoms, but may have additional occipital headache, ataxia, and nystagmus. So here they're kind of giving you a differential. Like labyrinthitis can look a lot like lateral pontine or cerebellar stroke. So you really have to use your best judgment to understand which one of the two it really is. And oftentimes it's really only going to be evident from the clinical aspect of things, nothing else, just how the patient presented, any other symptoms they may have. We've looked at a couple vascular disorders already, right? So we looked at the strokes and the hemorrhages that can occur, and all of them had a lot of what we refer to as focal issues, right? There won't be any focal issues if it's just labyrinthitis. If it's just the ear canals that's a problem, then there shouldn't be any focal deficits in the person. So as soon as they have focal deficits, then you start thinking of central issues. Vestibular neuritis, this lacks auditory or oral symptoms. Lateral medullary cerebellar stroke can present with similar symptoms as well, right? So again, with both of them, lateral pontine or lateral medullary strokes are going to be very similar to the two labyrinthitis or vestibular neuritis. However, again, the lack of focal issues, the lack of not being able to talk or not sensing something, not being able to move a certain muscle, right? Those kinds of neurologic deficits, they're not going to be there. So when those deficits are not there, you know it's not a stroke, all right? And differentiating between labyrinthitis and vestibular neuritis, that's really not something you're going to get tested on because you can't per se. But let's see what else they say here. A diagnosis of exclusion once the more serious causes of vertigo have been ruled out. Acute peripheral vestibulopathy demonstrates the following: an abnormal vestibulo-ocular reflex as determined by a bedside head impulse test, rapid head rotation from lateral to center while staring at the examiner's nose. Right? You tell them to do this and they start getting very confused because there's too much vertigo. A predominantly horizontal nystagmus that always beats in one direction opposite the lesion. Right? This is going to be pretty key in identifying it. So horizontal nystagmus, so your eye keeps moving from like left to right, but determining which side it's really moving to is the thing. So is it moving to the right a lot? Then if your eye keeps having nystagmus towards the right a lot, then it's an issue with the left vestibulocochlear nerve or the left ear canal. No vertical eye misalignment by alternate cover testing, right? So covering one eye and checking. Vertical nystagmus is more so a brain lesion, and vertical nystagmus is also often seen in penialoma, or you might even see it in some drug overdoses, but not in a vertigo-related question, right? If patients are high risk, such as patients who have atypical eye findings or neurologic symptoms or signs, cannot stand independently, have head or neck pain, are over 50 years of age, or have one or more of the stroke risk factors, then do an MRI with diffusion-weighted imaging, because their high-risk issue usually means that they might even have a tumor or something, and you need to check. Acute treatment consists of corticosteroids given under 72 hours after symptom onset and anti-vertigo agents like meclizine. The condition usually subsides spontaneously within weeks to months. Right? So this is a type of vertigo that really mimics central vertigo because it has things that it can look like. Just keep in mind that any central thing is going to have focal lesions, focal deficits, and if you don't see any focal deficits, then it's not a central stroke. Here we have a question related to this stuff. So it's a 64-year-old woman, so she's really old. Right, 64-year-old woman. Emergency due to sudden onset headache with nausea, vomiting, and a sensation that the room is spinning. So usually I don't highlight anything in that first sentence with what the patient is talking about, but from reading this first sentence we can kind of tell where the question must be going. Besides the fact that we're obviously doing vertigo stuff, if you were doing this question on your step 1 and you read that the room is spinning, you would know that this question may be about vertigo. So we would highlight the vomiting part because that's a pretty key thing. Right? Vomiting is an action that we do in under really just 2 scenarios, as we've said before. Either you ingested something that you shouldn't have, or like ingested too much alcohol, or had really bad rotten food. Right? Those are things that can make you vomit, or you have some kind of central issue, some kind of brain issue. She has had no ear pain, hearing loss, fever, or chills, was recently prescribed ACTZ and lisinopril for hypertension. Medical history includes diabetes and hyperlipidemia. She does not smoke or drink. Blood pressure is fine. Pulse is fine, so the medications are helping. Neurologic exam with the patient lying still shows pure rotatory nystagmus, right? So rotatory nystagmus, we highlight nystagmus. Anytime you ever see nystagmus, you care about that. But no extremity weakness or sensory loss. So you see, they're ruling out whether or not this is a stroke because there's no extremity weakness or sensory loss. So basically there's no focal lesion. So it's not a stroke in any way whatsoever. Walking causes worsening of symptoms and he falls toward the left side. So now that's a little weird, right? So walking, he falls towards the left side. So we're going to highlight that, right? So falls towards the left side. Finger stick glucose is 145, slightly higher than you would want it to be. Right, and the patient is diabetic, so maybe needs better diabetes medication. CBC and serum electrolytes are normal. What's the next best step in her management? So they chose non-contrast CT of the head. 50% of people chose that. But 35% of people chose autonomous repositioning maneuver, which is the Dix-Hallpike and Eppley maneuver. So why was it not the Dix-Hallpike or Eppley maneuver? This patient with vascular risk factors, acute onset headache, a sensation that the room is spinning, and nystagmus likely has had a stroke. So how was it that they were able to try giving you things in the question that were not, focal deficits, but then they were able to actually convince you that this is a person with stroke. Well, remember this asterisk right here. Right? We read about this just now, about how when is a patient considered to be high risk. So it's not just about focal deficits, right? It's not just about focal deficits. This is someone who's really old. She has vomiting, right? She has conditions that are considered things that worsen vascular disorders. Diabetes is inflammatory for blood vessels because of the non-enzymatic glycation that occurs. Hyperlipidemia is also inflammatory because atherosclerosis is inflammatory for blood vessels, right? And then nystagmus is nystagmus that you can see in anything really, both of the different types of vertigo issues. But then the falling toward one side, we saw where did we look already where someone can fall on one side? Well, that was with cerebellar lesions, right? When you have a cerebellar lesion on one side, if someone injured your left cerebellum, you will fall towards the left side, right? And the way they worded this falling toward one side kind of thing, it was pretty significant. So this question did a pretty good job showing things that you wouldn't see in a person who just has pure vertigo, right? Especially the new onset headache, sensation, room spelling. The most concerning things in this question were the vomiting, the headache, and the falls toward the side lesion, right? So this was actually a stroke or hemorrhage affecting the cerebellum. This one line itself should immediately always make you think of a cerebellar lesion. Someone keeps falling toward a certain side, that's when you know that the lesion is on that side cerebellum, same side cerebellum, ipsilateral. Vertigo is often described as a sensation of spinning, whirling, or tilting, and can be due to an underlying disease in either the central or peripheral nervous system. Patients with central vertigo have nystagmus that is not fatigable and not inhibited by fixation of gaze. They may be unable to walk because, in addition to a false sensation of movement, vertigo from a central underlying cause may also affect postural stability and coordination. Patients with certain central vertigo should be evaluated for cerebellar stroke or hemorrhage, particularly if they have prominent stroke risk factors like new onset headache or neurologic symptoms. A CT scan is often obtained first because it can be obtained faster than an MRI. Right? So it wasn't an answer choice to pick an MRI. Oftentimes you may not have CT as an answer choice and the MRI is the answer choice to pick, so you pick it. Other times you can have both answer choices, CT and MRI, so you have to be careful. This question may have had an MRI as an answer choice also, which is why they're probably explaining this. So you know this on CK and in step 1, that you can have multiple correct answer choices, but one is more correct than the others. So CT is the way to go, because it's quicker, it's cheaper, it's very easy to do, and it shows you a lot of things. If CT is somehow negative, MRI is required to exclude brainstem or cerebellar pathology. Odd-length repositioning with the Eppley maneuver is used for BPPV, which does not cause headache but affects the semicircular canals and therefore has characteristics of peripheral vertigo. And those people don't really tend to fall that much on any side. They can stop their vertigo by fixing their gaze on one thing and not moving their head. Right? That's what they have to do, and then they'll be okay. This person keeps falling. Right? So walking worsens things. They keep walking. They have rotatory nystagmus. All these things. Right? So something's much more fishy than just general vertigo in this question. Next thing here, Meniere disease. So Meniere disease gets tested as well a lot, especially on step 1. A cause of recurrent vertigo with unilateral auditory symptoms that affect at least 1 in 500 individuals in the United States. More common among women. This disorder of the inner ear is characterized by increased volume of endolymph. That's too much fluid inside the ear canals. Presents with recurrent episodes of severe vertigo, hearing loss, tinnitus, and ear fullness. Episodes often lasting minutes to hours. Nausea and vomiting are typical. Patients progressively lose low-frequency hearing over years and may become deaf on the affected side. So this has some symptoms that are looking like red flag symptoms, right? We got the vomiting, we got the hearing loss, the unilateral deafness. So it's a little scary, and definitely much more scary than general vertigo, but it's still not central vertigo. It's just a lot of endolymph, and basically these people need to seek out treatment as quickly as possible. Rule out cerebellopontine angle tumors by MRI, right? So cerebellopontine angle tumors are your there's a couple actually, cranial nerve 7, cranial nerve 8, all of them can cause tumors in that cerebellopontine angle. If you haven't seen the cerebellopontine angle in a while, Let me see if I can find that real quick. There's a pretty good picture for it. Let's see. Yeah, right here. So cerebellopontine angle with acoustic schwannoma. So there's a couple cranial nerves in here, right? So they're showing the cranial nerve 8, causing an acoustic schwannoma. And this is the cerebellopontine angle, it's a triangle. Inside here, you also have cranial nerve 5, 8, and 7. All of them are in this angle. Right, so all of them can actually cause the same kind of thing. Now, again, we've seen this already, right? We studied this kind of an image where we counted down all the different nerves. Right, we're basically starting with your optic nerve. You don't see cranial nerve 1, the one that's for smelling. Number 2, and then you would count out everything else. They cut out 3 and 4 from the picture here. You don't see 3 and 4 in this image either. And you can see some of the other ones over here. Right, so you should always be able to count out all the cranial nerves anytime you're presenting such an image, just for your own practice purposes, really. And then here they're showing you how an acoustic schwannoma can cause issues, right? So this is going to be really bad. And I mentioned earlier that the facial nerve is a huge part of the ear. Right? You can see how even in this image they're doing a good job showing you how the facial nerve is passing by in this. So oftentimes people who have any kind of acoustic neuroma, acoustic schwannoma kind of an issue, the facial nerve gets involved. Of course the cochlear nerve will be, and hearing is going to be affected, but even the facial nerve gets involved, and that's often going to be a question you have to watch out for. They go on to say then the diagnosis is made clinically and is based on a thorough history and physical exam. 2 episodes lasting more than 20 minutes with remission of symptoms between episodes, hearing loss documented at least once with audiometry, and tinnitus or aural fullness are needed to make the diagnosis once other causes like transient ischemic attack and autosyphilis have been ruled out. Right? Syphilis of the ear nerves have to be ruled out. So again, this autosyphilis, I've never actually seen a question on it, but they've written it here. So they're basically just trying to tell you that rule out things before you actually decide that it is just Meniere disease. And Meniere disease is scary, so you wanna decide it's Meniere disease as quickly as you can because you don't want to waste time. Acutely, you could use meclizine or benzodiazepines to control the spinning sensation during acute attacks, antiemetics for nausea, vomiting. Chronic, dietary changes that limit salt intake to avoid fluid retention, and diuretics. For severe unilateral cases, intratympanic injection of gentamicin into the middle ear has been shown to reduce the frequency and severity of vertigo attacks. Right? So we're seeing the most treatment right here. This one had the most treatment. Right? It got worse as we kept going. The others didn't have that much treatment. All right. And then the next topic here is syncope, which is a huge deal because, as I mentioned a couple videos ago, we found more questions for syncope. So we're going to read this here and then go back to cardiovascular syncope and do those questions. But before we do that, let's revisit vertigo in step 1. Right? So we have some question. We have one question here too. So they differentiate the 2 types here. They don't really dive into too much of it. It's more of just listing it out. Right? So generally the same things we just talked about. But I do want to look at this question. So this one says a 42-year-old woman comes to the office to discuss dizziness. She has a 6-month history of episodic bouts of a spinning sensation associated with nausea and ringing in her left ear. So that's tinnitus, spinning sensation of vertigo, keeps happening, so it's chronic. The patient also has difficulty hearing from her left ear, but her right ear is normal, so loss of hearing as well. Right, so already from these symptoms alone, you know this is Meniere disease. Right, the tinnitus, the lack of hearing, and the vertigo. The dizziness improves spontaneously and is fine between episodes. Past medical history has hypothyroidism, for which she is on levothyroxine, and endometriosis, for which she got a hysterectomy at age 38. She does not use tobacco or alcohol. The condition is most likely a result of what? Increased endolymph in the inner ear. It's Meniere disease. Right? What would you do for her? Maybe give her tell her to take a low salt diet and give her diuretics, right? And hopefully things get better. For symptomatic relief, you can always tell them to just use meclizine and they'll feel better, but they can't keep using meclizine. They need to fix the issue. Meclizine is just for symptomatic management. All right. So now syncope. One of the most common causes of loss of consciousness, secondary to a sudden drop in cerebral perfusion. Etiologies can be cardiac or non-cardiac. Presyncope can be associated with non-cardiac causes and is described as a feeling of imminent loss of consciousness without actual fainting, commonly confused with seizures. Right? Patients may report a trigger like orthostatics, standing for a long period of time, fear or sight of blood, so a phobia-related syncope, and Valsalva maneuver. Non-cardiac typically involves prodromal symptoms that lead to loss of consciousness and muscle tone for less than 30 seconds and recovery within seconds. Screen for the following potential etiologies. Orthostatic hypotension, symptoms triggered by postural changes. Common causes include dehydration and autonomic neuropathy, commonly seen in patients with diabetes. And we're going to see this in the questions we're going to look at. The other thing, vasovagal, sudden increase in vagal tone triggered by prolonged standing, emotional distress, painful stimuli. Patient may experience prodromal symptoms of nausea, warmth, and diaphoresis before the syncope. So vasovagal and orthostatic were both considered non-cardiac. All right. Then there is cardiac syncope. Does not typically involve prodromal or postdromal symptoms. Patient may have history of arrhythmia, valvular disease, or even structural heart disease. Screen for the following etiologies. Left ventricular outflow tract obstruction, such as aortic stenosis or hypertrophic obstructive cardiomyopathy, syncope with exertion or during exercise. Right? So when someone gets syncope while doing a stress test, that's a cardiac syncope. Right? Whereas the orthostatic and vasovagal ones, those are non-cardiac. Those are not because of your heart. Those are because of either the blood vessels or your nervous system. Then they go say arrhythmia, history of coronary artery disease, MI, cardiomyopathy, Wolff-Parkinson syndrome, anything else that could cause an arrhythmia. And torsades, triggered by electrolyte abnormalities of potassium and magnesium. Diagnosis: unless there is a clear vasovagal syncope in a young patient with no history of cardiac disease or risk factors, place all patients on telemetry or Holter monitoring. Right? So telemetry or Holter monitoring are going to be answer choices. These are going to be answer choices for every syncope question you ever get. They're not always the correct answer choice. Right? Again, as we said here, unless there is a clear vasovagal syncope in a young patient with no history of cardiac disease, right? If you see that, then you don't need to do telemetry or Holter. If you don't see that, right, there is not a clear vasovagal syncope, then you need to do telemetry or Holter monitoring to evaluate for arrhythmia and rule out myocardial ischemia with an ECG. Consider an echo, a tilt table test, or neuroimaging, especially vascular imaging. Consider seizure and rule out with an electroencephalogram if the following occur. Patient experiences limb jerking that is unilateral. Patient has prolonged confusion after the episode. Patient bites the lateral aspect of his or her tongue. Right? All of which we looked at when we looked at seizures that can occur. Right? And seizures, we just looked at a lot of it yesterday. Right? Headaches and seizures. We saw the limb jerking that can occur in unilateral for the focal partial seizures. Right? And then confusion after complex seizures that were diffuse in the whole brain. And biting the tongue, also part of complex seizures and diffuse seizures, not the partial ones. Now, the main thing here comes to management of the patient, right? Which, again, when they say this, it makes the answer very difficult to pick, right? Treat the underlying cause and avoid triggers. Well, now you have to get good at figuring out the underlying cause by looking at a bunch of practice questions. And we can see that now. Let's go back to cardiovascular. The last topic in cardiovascular was syncope. Right? It was a chapter, the ending of that chapter, right, where they just talk about cardiac, neurologic, and other reasons of syncope. They mentioned some triggers and stuff that can occur, and again, treatment was just tailored to the etiology. So now let's look at how we're supposed to work with that. There's a bunch of practice questions here to help kind of figure out what's happening. Let me just make sure which ones are actually related to syncope. So this is vascular disorder. This one we did too is echo. Ankle-brachial index was an answer choice. This is also a vascular. So we've done those questions. So this is the page that I added recently where I found a bunch of syncope related topics. So let's take a look at this first one. You're going to see things that you probably haven't seen still in any of this book. We didn't see it in this section of syncope, and we didn't just see it in neurologic section of syncope either. It wasn't in either of those places. So here it says, 22-year-old woman is brought to the office by her mom due to recurrent syncopal episodes. Right, so she's 22. First episode occurred about a year ago when her roommate committed suicide. So it seems like it was related to some kind of emotional trauma there. She has had several similar episodes since then, often provoked by strong emotions. So I'll definitely underline that. The episodes are preceded by lightheadedness, weakness, and blurred vision. So I'm going to underline preceded by, because what I'm thinking here is that there was an aura, right? That's what these things mean. When something precedes an episode, that is the aura. So her aura is going to be the lightheadedness, weakness, and blurred vision, where she will now know she's about to have syncope. Last about 3 minutes, so each episode was about 3 minutes, and end with rapid recovery of consciousness, okay? She has had no injuries related to syncope except once when she had superficial bruises, okay? Her medical history is insignificant, takes no medications, doesn't drink or use drugs, blood pressure is fine, doesn't really change much between being supine and standing, right? 110, 108 stayed the same. Physical exam findings are normal. ECG performed a month ago was normal. What's the next best step? So they already did the ECG, right? In the question, remember, questions teach you how to manage. So they ruled out cardiac stuff by doing the ECG. So since they ruled out cardiac stuff, you don't need to do anything for cardiac stuff anymore. But however, 25% of people still chose to use a 24-hour Holter monitoring. So Holter monitoring, as we just saw, let's see. Where was it? Yeah, Holter monitoring and the telemetry were things for patients who needed more evaluation of arrhythmia, right? But we already did the ECG. If the ECG was normal, then it's probably not going to be an arrhythmia. You rule out MI with the ECG, yeah, because you would see elevations like ST elevation, ST depression. You would look at 2,3 AVR, 2,3 AVF and whatnot, right? I get that, but on an ECG, that's also how you rule out arrhythmias. Since they already did the ECG and everything was fine, you don't need to do a 24-hour Holter monitoring. Also, they said you don't need to do Holter monitoring if there's a clear vasovagal syncope in a young patient. And if you look at our patient right now, it's a young patient, which seems like vasovagal syncope because it's strong emotion. Remember, I keep mentioning how the vagus nerve goes all the way down to your stomach, and when something really traumatic, emotionally traumatic occurs, your stomach sinks, right? That's a vasovagal response. So this is a vagal response too. She keeps having these vagal responses to strong emotion moments. Like someone committing suicide right there is pretty traumatic to hear about. And they also ruled out orthostatic because supine and standing blood pressure were the same. So the only answer that was worth picking here was using counterpressure maneuver education, something that isn't mentioned in the book anywhere, right? So you learn about it when you do questions, and it should be in the book. In all honesty, of course it should be in the book. This is something that you need to know about, but it's not. So that's why the annotated version is so critical. Counterpressure maneuver education was the correct answer choice, and 50% of people picked it. That means 50% of people got this question wrong, of which a quarter of the whole chose this wrong answer choice that really shouldn't have been chosen. Right? Maybe these people didn't know what Holter monitoring was. Like a few of them may not have known what Holter monitoring really was. Neurocardiogenic, which is vasovagal syncope, can be triggered by emotional or painful stimuli and is frequently associated with prodromal symptoms prior to the syncopal episode, which is the preceded by aspect. The prognosis is excellent. For patients with recurrent syncope, management consists of advising patients to avoid triggers and to assume a supine position with leg raising at the onset of symptoms. Right? That's it. That's all they have to do. And this often also works for any other syncope too, but it's key here. Right? So recurrent syncope, just do this. Right? So avoid triggers, assume a supine position with leg raising at the onset of symptoms. So that could be another answer choice. Instead of picking counterpressure maneuver, the answer could be just leg raising. Right? Assume a supine position with leg raising. So that you have to be very careful with that. All right. So just lay down and raise your legs. Physical counterpressure maneuvers of leg crossing with tensing of muscles, hand grip, and tensing of arm muscles with clenched fists. Right? Many different ways of doing it. During the prodromal phase, can improve venous return and cardiac output, sometimes aborting the syncopal episode. Some patients in high-risk settings associated with a potential risk of physical injury require temporary activity restriction until these maneuvers are proven to be effective. Right, so you should not be flying a plane or driving a car too much if you have chronic syncope. Holter monitoring is indicated in patients with clinical ECG features suggesting the presence of an underlying arrhythmia in patients who usually have underlying heart disease and present with syncopal episodes without triggers. But she has triggers. So it wasn't an ECG thing. It wasn't a cardiac thing. She clearly has triggers. They made it very clear to you in the question she has triggers, right? So vasovagal and situational syncope. Pain, anxiety, emotional stress, heat, prolonged standing, right? Situational is cough, micturition, defecation, eating, or hair combing. Two different types. We just saw the one about this one. So each of these things, separated by commas, can be a question of its own. Right? Question of its own. We're going to see another one soon here about micturition too, that urinating made them feel like they were about to have syncope. That's in here as well. Right, so each of these things is a question of its own. You need to be very careful in recognizing those syncope questions and then organizing it into vasovagal, right? Vasovagal and situational. The prodrome is a key thing here in clinical presentation. Rapid recovery is a key thing. They also put that here, right? Recovered in 3 minutes. Diagnosis, just do the tilt table testing. They didn't do that here because we didn't get to that part yet. Right, with the best next step in her management, it was pretty clear from the question from the clinical presentation. You don't need to do the tilt testing for her because it's not uncertain. It's very clear. It's very clear that she has emotional vasovagal syncope, so just give her the education she needs. And that's it, just reassurance and avoidance of triggers. There's really not much else to do with her because this has great prognosis, so she's going to be just fine. Right? Then we look at the next question here, 21. So again, a young person, 21-year-old woman evaluated for syncope. She has recurrent episodes of syncope since her mid-teens. So if you're doing this on your real test and you read these two sentences, this is checking off whether or not you need to do a Holter monitoring. So to check that off, we need to find a trigger. We need to see if she has anything that precedes these triggers, right? So an aura, a prodromal moment, and how long does it last, and is there anything that makes it better? Right, then we probably don't need to do Holter monitoring. You do need Holter monitoring if the patient has conditions that would increase the risk of her having an MI, history of MI, coronary artery disease, stuff like that. She's very young, so already it seems very unlikely that she's going to need Holter monitoring. The first episode happened when she was having blood drawn for a test. So we can see some level of a trigger here. Right? Maybe she is really scared of needles or scared of blood. Right? Either one of those two. She has also passed out several times while standing in a crowded church. So those two are pretty weird to have in the same person. They're not really connected to each other, but we're seeing triggers nonetheless. The syncope is typically preceded by a feeling of warmth. So there's an aura, right? Diaphoresis and nausea. During one episode, she had a minor head injury and facial laceration. So she just completely falls, right? These are dangerous falls. Her medical history is otherwise insignificant. She takes no medications. Blood pressure's 122 standing, 125 laying down. So no changes, no orthostatic changes, right? Pulse is regular and fine. Physical exam is fine. They did the ECG. ECG is normal. Right? ECG has nothing wrong. So that's all great too. So we really don't need Holter monitoring here. Long-term ECG monitoring is most likely to show which of the following immediate preceding and during the syncopal episodes. Okay, so they're saying if you did do Holter monitoring, or if you were just monitoring her heart in these moments of her syncopes, what would you see? Right, so we all know, right, that when you're about to have syncope, it's usually a moment where the reason you got the syncope was because your heart rate was slow and there wasn't enough blood coming to the brain. That being said, the simplest answer and the easiest answer choice to pick is bradycardia and sinus arrest. Slow heart rate with possible sinus arrest in the moment of the syncope. I have no idea why 30% of people chose sinus tachycardia where your heart rate is high. If your heart rate is high, then you're maybe running or something, in which case that's not syncope, right? That's exercise. That's great blood supply. So it really didn't make sense at all to pick sinus tachycardia. That's the exact opposite of what we're thinking of when we think of somebody having syncope. She most likely has, once again, vasovagal syncope, which occurs due to an alteration in autonomic drive. Most commonly, abrupt parasympathetic activation, vagus nerve, leads to cardioinhibitory response that manifests as bradycardia with sinus arrest. Less commonly, decreased sympathetic drive leads to a vasodepressor response, resulting in peripheral vasodilation and abrupt hypotension. In both scenarios, cerebral perfusion suddenly decreases and syncope occurs. The episode resolves quick as cerebral perfusion is rapidly restored. Vasovagal syncope most commonly affects young patients and is often triggered by an emotional stress, like her fear of venipuncture. A prodrome of nausea, diaphoresis, and pallor often precedes the vasovagal syncope, as opposed to other causes like cardiogenic syncope, which wouldn't have a prodrome. The normal orthostatic blood pressure rules out orthostatic syncope. Sinus tachycardia is seen in atrial arrhythmias like atrial fibrillation or ventricular arrhythmias like VTEC. However, that's going to be cardiogenic syncope, and that's not what her issue is. The syncope is sudden. Patients may experience palpitations prior to the episode, but a prodrome of nausea and diaphoresis is not typical. Right? So it couldn't be. So sinus tachycardia was not the answer. This one is explaining why it's not sinus tachycardia. She doesn't have AFib. She doesn't have any kind of cardiogenic issue. So you don't do sinus tachycardia as the answer choice, right? So both of these questions here, the first two that we've done, have a young patient with some kind of trigger that led to a minor, a temporary small moment of syncope that they completely recovered from and moved on in life with, right? And all they needed to do was just follow counterpressure maneuvers and avoid those triggers, and they'll be fine. Right, so this is great. This is the, if you will have some kind of syncope, this is the best one to have because it has a great prognosis. Now here comes some more problematic ones. So now we're going to look at cardiogenic syncope. And you can see immediately how the question shifts gears. Now we're with a really old person, so a 67-year-old man, brought to the emergency department after a syncopal episode. He lost consciousness while shopping in a mall. So he was shopping. So that's not necessarily a trigger. He was actually just doing something completely normal. Like he was just out and about on a normal day. No triggers so far. He has no nausea, diaphoresis, or chest pain. So you can see no prodrome, right? No kind of aura. He has had 2 episodes of lightheadedness over the past month, but has not sought treatment. His other medical problems include long-standing hypertension, which is being treated with enalapril. Today, his blood pressure is 135/90 while supine and 130/85 while standing. So in both cases, it's slightly high, but it's not like really bad high, and it doesn't change, so it's not orthostatic. Pulse is 64. This is a little bit on the slower end. Right, so a little bit on the slower end because 60 is going to be the lower end, and if you give him a beta blocker or anything that slows down heart rates, he's probably going to have too slow of a heart rate. So Ramadan started today, so there's going to be a lot of yawning and a lot of me getting really thirsty from talking for this entire month, so be ready for that. ECG shows sinus rhythm with high voltage, prolonged PR interval, prolonged QRS complex duration, normal QT interval, and occasional premature ventricular contractions. Okay, so ECG is showing a lot of shit, right? There's a lot of problems. Like, this is not a normal ECG, right? So there's problems here. The most notable problem being the prolonged PR interval. So the filling is of the atria into the ventricle. That's prolonged, and a lot of this might actually be the reason why this patient has such a slow pulse, right? Premature ventricular contractions are also occurring, which is scary because that can eventually mature into a ventricular fibrillation, which is usually just fatal. You die. BMP is unremarkable, so nothing wrong with the basic metabolic panel. Echo, so they did ECG and they did echo, shows left ventricular hypertrophy and a normal ejection fraction. What's the most likely cause of his syncope? Well, of all the things I've underlined, right, the only thing I can see that could be causing syncope is the thing we just talked about earlier that causes syncope in the previous question, bradycardia, slow down heart rate, so bradyarrhythmia, right? Because he has an ECG and echo abnormality with a slow pulse, and he has long-standing hypertension that isn't optimally managed. It's managed, but not perfectly. So bradyarrhythmia was the answer choice to pick here. 20% of people chose premature ventricular beats being the reason of a syncope, which I can definitely respect. Makes sense to be able to pick that as an answer choice, but bradyarrhythmia is a better answer choice, just an arrhythmia where the heart rate is slow. Syncope refers to an abrupt and transient loss of consciousness with loss of posterior tone, followed by a spontaneous and complete recovery. It is usually benign and self-limiting, like vasovagal syncope, but it can be the initial presenting symptom of a life-threatening disease process called cardiogenic syncope, which is far worse. The cause can be often determined by careful history taking, physical exams, simple labs, and ECG. He has conduction system abnormalities, many that are seen in his ECG, including the PR interval and intraventricular conduction delay, causing the prolonged QRS duration on his initial ECG. This is suggestive of a bradyarrhythmia or a high-grade AV block as the most likely cause of his syncopal episode. AV block with associated bradyarrhythmia can be quite intermittent and is likely responsible for his prior episodes of syncope. The fact that his heart rate is currently normal does not exclude bradyarrhythmia due to intermittent nature of the block in many patients. And although this is under the normal range of 60 to 100, I don't really want to see a 67-year-old patient with a heart rate of 64. Because when the elderly have a heart rate that's approaching the lower end, that's concerning. Because then you're not too far from going from 64 to 54. That's not that far, right? You don't want them to have cardiac arrest while they're resting and just sleeping or something. So this is pretty concerning. And you start checking, like, should I do something for this person to have a quicker heart rate? He should be referred to exclude bradyarrhythmia due to the intermittent nature of the block in many patients. He should be referred for additional electrophysiologic testing and evaluation for a pacemaker. See? So we should do something to make sure that his heart doesn't become too slow and he dies. The other answer choice, premature ventricular beats, are usually asymptomatic or can cause palpitations, but isolated premature ventricular beats in a patient with normal ejection fraction are not associated with syncope. So that wouldn't be the root cause of a syncope. The other thing would be. Right, so you can see now 5 different questions you can get regarding cardiogenic syncope. Our guy was most likely advanced AV block. There are other case scenarios where you can have cardiogenic syncope. Right, so you need to make sure you can catch each of these as a question when they occur. Right, so we see almost 20 questions here, right, with each comma separating them, each of these being a question of its own, and then 5 questions right here regarding cardiogenic syncope, which is far more dangerous, doesn't have a good prognosis, and you need to do something about it. Last question here, again, a 60-year-old man brought to the emergency department by his wife after a syncopal episode. According to the patient, he woke up in the middle of the night and went to the bathroom to urinate. Okay, so that could be a trigger. Although it's a completely normal thing to do, it could be a trigger. Right, so you need to keep that in mind. He felt lightheaded while urinating and then fainted there. So that tells you that most likely was a trigger. He has never had such an episode before. He drank a lot of fluid in the evening before, but did not use any alcohol. He has had problems with urination, including difficulty initiating urination and frequent awakening to void at night. So this difficulty initiating urination and frequent awakening to void at night are signs that this old man may have prostatic hyperplasia. Right? So that's what happens when your prostate becomes really big. You can't really pee correctly, and you keep waking up to pee because you have the sensation of a full bladder. But every time you go to pee, you really can't because the prostate is squeezing your urethra from actually peeing correctly, right? So that's a different problem. That's a different thing, but definitely tells you something about him. Doesn't take any meds. Medical history is fine. Blood pressure is fine. It doesn't have any orthostatic changes. Pulse is fine. Physical exam and ECG are fine. So then what's most likely causing a syncopal episode? Cardio inhibitory response. which is once again the same thing as the vasovagal one. Right? This clinical presentation of transient loss of consciousness along with loss of postural or motor tone during urination is consistent with situational post-micturition syncope, a form of vasovagal syncope associated with specific triggers like we see right here, the urination one, the micturition, situational. Right? A lot more things that cause vasovagal syncope, and these topics that cause cardiogenic syncope are usually going to have a question about something else rather than the syncope. Right? They usually want to test you on these things to ask you about some other cardiovascular thing, not the syncope question. Syncope is a question which is honestly an easy question, so that's why it won't be a question. And if it is, you should be happy that it is, so you can pick it. The diagnosis is made by clinical history, specific triggers for reflex syncope causing alteration in the autonomic response, and can lead to a cardioinhibitory, vasodepressor, or mixed response. Increased parasympathetic stimulation, especially when you're trying to pee, that's a parasympathetic thing, rest and digest. Increased parasympathetic stimulation can manifest as bradycardia, varying degrees of AV block, or asystole. And then the decreased sympathetic output can lead to vasodilation, hypotension, or syncope. So together, these two guys are going to make syncope occur. Now, on this table, you have the full understanding, full breakdown of every kind of syncope you could possibly get tested on. Right? Some of which we saw on the other thing in neuro, some of which we saw right here. Generally speaking, though, you want to just have a good understanding of each of these so that when you read any of these things, you can figure out that that's the kind of syncope you're thinking of. So like this one is often tested too, the carotid hypersensitivity. Remember that if you do a carotid sinus massage, you increase your AV node refractory period. Remember that a massage is a parasympathetic thing, right? So if you do a carotid sinus massage, you slow down how quickly your AV node works. That's what it means to increase the AV node refractory period. So once the AV node shoots a signal, it takes a longer refractory period for it to shoot the same signal again. That's where would you have a person who's maybe causing carotid hypersensitivity? Usually it's going to be a man who's wearing a collared shirt and the collar or the tie was too tight. Right? That's going to end up massaging their carotid without them really noticing that they're massaging their carotid, and then they can just have syncope, which causes them to faint. Right? So that's going to be the carotid hypersensitivity aspect of things. Medications, of course, many of them can cause it. This is going to be critical with what we looked at earlier called the Beers criteria. It's something that you always need to revisit. It's not just a one chapter thing. The Beers criteria is a list of medications you don't give to elderly patients because they can cause syncope. And elderly patients having syncope is very dangerous because when they fall, it's far worse than when this 21-year-old woman is going to fall. Because when she fell, this 21-year-old woman fell, she had a minor head injury and a facial laceration. If a 67-year-old woman fell, she would probably have a major head trauma and breaking of facial bones, possibly even hip displacement and other things along those lines, right? So that's really dangerous. So the Beers criteria plays a big role here. Hypovolemia, of course, anyone that's vomiting too much or is extremely dehydrated because they were stuck in a desert or something, right? Those kinds of questions. Autonomic dysfunction, you're going to see anyone who has some kind of issue that would cause nerves to not really work too well. Right? They're also going to be in the same. So these are all things that have orthostatic syncope, right? Because in all of them, the movement of the response of your blood vessels to movement is not going to be very good, right? So movement being that laying down and standing are going to cause major changes, right? Hypovolemia is a loss of fluid. And when you stand, you have a loss of fluid because blood moves from the heart into the legs, gravity. And that should not cause hypotension in the normal individual, but in them it will. In them it will. When they stand up, their body with autonomic dysfunction will not respond adequately to the movement of blood from the heart to the legs, and they'll get orthostatic syncope. Right? And then we just did the cardiac syncope stuff, right? This one right here, where the person's ECG and echo never really look too good. Right? You're going to see some kind of murmur in the echo, some kind of ECG abnormality, or just general ECG abnormalities that we're all used to. Right? So we can see key things in each of these that separate them very well. So you can easily group them into one. Well, let me not use check marks, but either 1, 2, or 3. Right? You have to group them into 1, 2, or 3 to figure out what you need to do. And these actually are in order of best prognosis to worst. I don't know if they meant to do that, but yeah, cardiac syncope has the worst prognosis because usually you can't do anything about it. Usually you can't not do anything about it. You have to do something about it, but it won't really help much. You know, and it's still scary. Like for this guy, we need to give him a pacemaker, right? That's a pretty big deal, as opposed to the first girl who just needs to raise her leg and lay down and she'll be all right. You know, so that's generally the full scope of syncope, and I'm glad that we were able to do this in this manner. So we finished it up in neuro and came back all the way to cardiovascular to wrap up syncope, right? And in our next video, we'll be going into disorders of the neuromuscular junction.